Cheah. I'm a consultant haematologist at Sir Charles Gardner and Hollywood Private Hospitals in Perth in Western Australia. Follicular lymphoma is the most common slow-growing lymphoma. It makes up around 25% of all lymphoma diagnoses, or probably around 1,500 to 2,000 patients a year in Australia. The median age at diagnosis is around 60 years of age, and it again, like most lymphomas, patients normally feel an enlarged lymph node, which prompts them to go and see their GP, and the diagnosis is made on the basis of a biopsy, ideally what we call an excisional biopsy, where a surgeon takes a small piece of lymph node tissue out and we look at it under the microscope. So the question was, do all patients with follicular lymphoma have symptoms at the time of diagnosis? The short answer to that question is no, and particularly with follicular lymphoma, I mean, many patients notice a lump, which is the first thing that leads them to seek medical attention. But because follicular lymphoma is a slow-growing lymphoma, other patients can be diagnosed completely free from symptoms on the basis of a scan, normally a CT scan, performed for another reason. So someone has abdominal pain and their GP organises a scan of their abdomen to look for their gallbladder or something, and some enlarged lymph nodes are picked up. So that's another way that patients with follicular lymphoma are often diagnosed. So the question is how long patients may have follicular lymphoma prior to their diagnosis. Because follicular lymphoma is a slow-growing lymphoma, the lymph nodes increase in size gradually over months to years. So it's not uncommon when I first meet patients for them to tell me that they've had these enlarged glands present for many months, even a year or two, prior to seeking medical attention. It's sometimes the case that patients with follicular lymphoma have other symptoms as well, such as fevers, drenching sweats at night time, and weight loss, but that happens less frequently than in patients with aggressive lymphomas like diffuse large B-cell lymphoma. So the question is, what are the causes of follicular lymphoma? Much like other subtypes of lymphoma, we don't know why the majority of patients develop follicular lymphoma. We know that there are risk factors, and some of those risk factors overlap with other types of lymphoma, such as diffuse large B-cell lymphoma, suppression of the immune system, a family history of follicular lymphoma, and prior exposure to chemotherapy or radiation therapy. But honestly, in the majority of patients that we see, no clear risk factors are present. So the question is how we manage early stage follicular lymphoma. And this is an interesting question because the management has changed slightly in the last few years on the basis of a fairly large study which was performed by Australian and New Zealand investigators led by Michael McManus at Peter MacCallum Cancer Centre. So let me talk about what limited stage follicular lymphoma is. In the staging system for lymphoma, you can be staged between stage 1 and stage 4. Patients with stage 1 and stage 2 follicular lymphoma, meaning 1 or 2 lymph node areas on 1 or 2 respectively lymph node areas on the same side of the diaphragm or breathing muscle, have what we call limited stage follicular lymphoma. These are the minority of patients with follicular lymphoma, only about 10 to 15%, depending on which study you look at. The outcomes of these patients appears to be highly favourable, and traditionally these patients received radiation alone, and probably something like 60 to 70% of patients were potentially cured using radiation alone. Now, there was a reasonably large Australian study in which patients were randomised to either radiation alone or radiation with a chemotherapy program called CVP with rituximab. And the results of this study suggested that for patients who have had radiation therapy plus the addition of this chemotherapy with rituximab, RCVP, they appeared to have a longer, what we call progression-free survival, or in other words, it looked like the lymphoma stayed away for longer. and that was largely due to a reduction in the risk of a lymphoma coming back outside the area of the body that was given the radiation, which kind of makes sense, right? There was no difference in overall survival in that study. So on the basis of that, many of us are offering patients, particularly those who are younger, under 60 years of age, radiation plus the addition of RCVP chemotherapy afterward on the basis of these results. The question is limited stage follicular lymphoma curable? So the short answer to that is probably yes. Follicular lymphoma in limited stage is probably the one exception to the rule where most of us consider follicular lymphoma to be a type of blood cancer which is treatable but not curable, because you administer chemotherapy with rituximab to patients. They almost always go into remission, but then it almost always returns at some point. But patients with limited stage follicular lymphoma may be the one exception to that rule, and particularly when radiotherapy is used with or without RCVP, it appears that a reasonable proportion of patients, perhaps as high as 70%, if we're talking about stage 1 follicular lymphoma, are cured. The cure rate is probably slightly lower for stage 2. What is the management for patients with advanced stage follicular lymphoma? Well, this really depends on the presence of symptoms related to follicular lymphoma, and the symptoms are basically, as we've alluded to earlier, the presence of rapidly enlarging lymph glands, the presence of an enlarged liver or a large spleen, the presence of low blood counts. So follicular lymphoma can get into the bone marrow and cause a reduction in your hemoglobin or your red blood cells and your platelets, which are cells which help you to form clots. And if that happens, that constitutes a reason to give treatment. If you have fevers or sweats or weight loss because of your lymphoma, then we consider that to be a reason to give treatment as well. And if the lymphoma gets into fluid, which is around the heart or in the abdomen or in the lungs, then that's a reason to give treatment as well. If a lymphoma is causing compression of something, so for instance, if you have a large lymph node which is squashing a blood vessel and causing a blood clot or pushing on a nerve, that would be a reason to give treatment. And if there was a high number of lymphoma cells floating around in the blood, we also use that as a reason to start treatment. Finally, there are a group of patients with follicular lymphoma who have very large lymph nodes in the body when we do a scan. And we know that, for instance, patients with a single lymph node which is greater than 7 centimetres in size, or 3 lymph nodes which are greater than 3 centimetres in size, which is about the size of a squash ball, then that we would consider that a reason to start treatment as well. So these are collectively known as the Guelph criteria, named after the French group who described them. The question is whether all patients with follicular lymphoma need immediate treatment. And the short answer to that is no. Most patients do not need treatment. I would say that the majority of patients with follicular lymphoma don't have any of these criteria for starting treatment at the time that they're first diagnosed. We know that a proportion of patients with advanced stage follicular lymphoma, particularly if you're older, may be observed for many years without needing therapy. Probably the average is about 2 or 3 years before needing treatment. On the other hand, there are some patients who present with one of those symptoms and do need immediate treatment. So the question is whether there are patients with follicular lymphoma who never need treatment. Yes, there are certainly patients with a very small amount of follicular lymphoma who, particularly who may be older and who may never require treatment for their follicular lymphoma. It's the minority of patients. Most patients will need treatment at some point in their lives, but there are a lucky few who will never need treatment, yes. So the question is what the names of treatment regimens used in the frontline management of follicular lymphoma are. This again is an area which has undergone quite a lot of change in the Australian context in the last 6 to 12 months. Let me talk about the chemotherapy first. In Australia, there are three main chemotherapy programs which we use. One is called CHOP, cyclophosphamide, doxorubicin, vincristine and prednisolone. This is a very common lymphoma regimen. We also use it for patients with high-grade or large cell lymphoma. The second chemotherapy program is called CVP, which is the same as CHOP, but it subtracts one drug, doxorubicin, which is the red one, which is slightly gentler in terms of lower risk of infection, lower risk of hair loss, slightly less effective in terms of its ability to control the lymphoma, but more suitable for older patients. The third chemotherapy which we use is called bendamustine, which again is given as an infusion, and again in contrast to CHOP and CVP, which are given once every 3 weeks, bendamustine is given on 2 consecutive days, once every 28 days or once a month. Bendamustine has the advantages of causing less hair loss, so it doesn't cause hair loss typically, unlike CHOP in particular. And it causes less problems with a side effect called neuropathy, where patients get tingling or numbness in their fingers or toes. But it does appear to be associated with a slightly higher risk of infection, particularly in patients over the age of 70. So it's a little bit of a trade-off, and your doctor will talk to you about what the most appropriate chemotherapy program might be. The second answer to the question is the monoclonal antibody. A monoclonal antibody is a medicine which binds to a protein called CD20 on the outside of a follicular lymphoma cell, or any B-cell lymphoma, to be honest, and it attracts the immune system. So really it's a form of immunotherapy. It binds to the outside of a lymphoma cell, and it then attracts your own immune system to attack the cancer. They work quite well in combination with chemotherapy. The commonest one, the one that's been around for the last 20 years, is called rituximab, and it's very effective in follicular lymphoma. It works well when given with any of those chemotherapy programs. More recently, there's been a large randomized study in which investigators compared rituximab with chemotherapy to a new antibody called obinutuzumab, or Gazyva, with chemotherapy, followed by 2 years of maintenance with the same treatment. And to cut a long story short, this study showed an advantage in terms of progression-free survival, which means that the lymphoma stayed away slightly longer in patients who were treated with this new antibody called obinutuzumab compared with the old antibody rituximab. There was a slightly higher risk of infection related to this, the newer antibody, but it did result in around about a 30% reduction in the risk of lymphoma returning. However, there was no difference in overall survival in this study. What is the prognosis of follicular lymphoma? Again, the answer to this question depends on the presence of some specific features, prognostic factors, which can be put into a scoring system that gives patients an idea of what their outcome with treatment is likely to be. In follicular lymphoma, that scoring system is called the Flippy score, or Follicular Lymphoma International Prognostic Index. There are a couple of variants of this. They take into account, they measure 2 things basically. One is how much lymphoma you have, and 2, how strong or how fit is the patient. We can basically take these features and plug them into a scoring system and then divide people into a very good, an intermediate and a high risk from their lymphoma, and we're able to slightly refine the prognosis that way.